Hi everyone, thanks for joining us on our latest session of Brown Bag Lunch Series. You're in for a real treat today. We have two marvelous ladies who will have a great presentation in store for you. Just a little bit of housekeeping. To ask a question, you're going to need to raise your hand and you can raise your hand and we'll get to them at the end when we have time, or you can put it directly into the chat box and we'll make sure all the questions that get entered in the chat box get answered either at the end of the presentation or after the presentation. Just a reminder, this is a Brown Bag Lunch series, so our hope is to train the trainers with these webinars. So our hope is that you will be able to go out and give presentations in your local community. We do have some funds available for food at your events. Please email me, Matthew Rose, at matthewr@blackaids.org for support on that. And our upcoming topics, we have Making Research Work for You, which will be a discussion of how to use databases to help support grant writing and policy briefs, as well as a discussion on HIV vaccines and HIV in the criminal justice system. But with that, I hand it over to our presenters, who are the fabulous ladies of SASE.
Hi everyone, this is Carolyn Mcallister. I direct SASE, which is the Southern HIV/AIDS Strategy Initiative, and we are based at Duke Law School at the Duke HIV/AIDS Policy Clinic. So just a little bit about what SASE is, and then I'm going to turn it over to our lead researcher, Susan Reif. We are a broad-based Southern coalition of HIV/AIDS advocates and their supporters, and we work to develop research-based policy and strategy recommendations for federal and state policymakers aimed at addressing the needs of communities hardest hit by the HIV epidemic in the Deep South. And our goals are to reduce HIV incidence, to increase access to care and improve health outcomes, and to reduce HIV-related health disparities. SASE has a steering committee of people living with HIV and AIDS and HIV/AIDS advocates from 9 Deep South states. And our major funders are the Ford Foundation and the Elton John AIDS Foundation. Next slide, please. So we work with researchers from the Duke Center for Health Policy and Inequalities Research, led by Susan Reif, who you'll hear from in a minute, to develop research-based policy and strategy recommendations aimed at securing a federal commitment and state commitments for the Deep South HIV epidemic. And we're focused, as I said, on 9 states, and those states are listed there on the slide that you see: Alabama, Florida, Georgia, Louisiana, Mississippi, South Carolina, North Carolina, Tennessee, and Texas. Next slide. And so I'm going to turn it over to Susan Reif to talk more about our research agenda, and then I'll come back and talk more about our advocacy agenda.
Okay, next slide, please.
I think we need to go back a slide, Susan. The overview slide.
Okay, I'm not seeing the next slide, so sorry.
Okay, so we're on the SASE research overview slide.
Hello, everyone. Thank you so much for joining today. As Carolyn said, I'm Susan Reif. I'm with the Center for Health Policy and Inequalities Research at Duke University. And our center has had the privilege of collaborating with SASE in their critical work at addressing HIV in the South. Today I'll be talking about some of the SASE-related research findings that have been completed over the last year, including a CDC-SASE collaboration that resulted in an article for publication last year, and as well as some trends in HIV epidemiology using HIV surveillance data from the CDC, and then also presenting some findings from our HIV Infrastructure Study that looked at care and prevention infrastructure in some selected metropolitan areas in sort of the targeted southern states that we're focusing on. These metropolitan areas have been particularly hard hit by HIV. And lastly, I'll be briefly touching on some of the research that we have planned for the next few years. And so I just want to say that all of the research, including the article collaboration with the CDC, is available on the SASE website. So please, if you're interested in knowing more, go to that website, which I think Carolyn has on a slide, upcoming slide. Next slide, please.
We got it.
Okay. So I want to just apologize in advance. Just let you know I'm not seeing the next slide, so I'm just going to go to my slide. I'm going to apologize in advance. I'm going to be presenting some figures and data, and so I know that can go a little tedious, so bear with me because I think all of this is really critical information to painting a picture of the HIV in our southern states of interest. As Carolyn said, we are really focused in our research in 9 states in the South that we refer to as the targeted states. These states have been disproportionately affected by HIV in recent years, and they also share some other similarities in terms of indicators of overall poor health, high poverty rates, and cultural climates that likely contribute to the spread of HIV in the state. Okay, next slide. Okay. So the CDC-SASE collaboration really stems from our interest in an article authored by the CDC and published in the Journal of Community Health in 2012, and that article looked at HIV in the South, and they used sort of the standard census definition of the South being 17 states and the District of Columbia, and so we were interested in replicating and expanding on their analysis, but with a focus on the 9 targeted southern states. So we're very fortunate to be able to enter into data agreement with the CDC where they performed our analysis of interest, and then we collaborated on the article I mentioned earlier. So next slide. So some of the main findings from that analysis was that HIV diagnosis rates are higher in the targeted states regions. And by HIV diagnosis rates, that just refers to the number of people diagnosed with HIV per 100,000 population in any given year. And the year in this case was 2011, which was the most recent available data at the time of the analysis. So then when we were able to look at some of the characteristics of people diagnosed with HIV in the targeted states in comparison to the U.S. overall, we found that their diagnoses were in the targeted states region were more likely to be female, Black or African American, young, age 13 to 24, more likely to be attributed to heterosexual transmission, and living in a rural area at the time of diagnosis. So next slide. And that slide just shows some of the difference in characteristics between the targeted states and the U.S. overall. For example, you can see 56.5% of people diagnosed in 2011 in the targeted states were Black or African American, self-reported, compared to the U.S. average of 46.6%. And you can also see the differences, particularly in terms of rural and suburban portions, people diagnosed with HIV. Okay, so next slide. So we also looked at HIV prevalence, which just refers to people living with HIV per 100,000 population. And we've looked at that in the past and seen that the Northeast has been consistently had the highest HIV prevalence rate. But when we looked more at characteristics of people living with HIV, we see that in the targeted states regions, there's actually a higher prevalence rate in rural and suburban areas than the Northeast or any other regions. And the other regions we use for comparison are the Census Bureau to find regions of Northeast, Midwest, and West. We also saw some differences in prevalence by age. I think it can best be illustrated by the next slide, please. So if you see in the yellow line, that's the Northeast. And when you look at age 45 to 54, you see the Northeast has much higher prevalence rates than the targeted states, which is in red, and the U.S., which is in orange. But when you go down to the younger ages, age 25 to 34 and 13 to 24, you can see that the rates between the targeted states and the Northeast are much more comparable. So it really shows that concentration at a younger age in terms of people living with HIV in the targeted states compared to Northeast and other regions. Okay, so next slide. We were also interested in looked at with this data HIV survival. So for people diagnosed with HIV in 2003 to 2004, we see that the targeted states had lower 5-year survival rates or proportions compared to other states. And when we just look at the targeted states, we see that HIV survival was lower among women, African Americans, and both living in rural areas at the time of diagnosis. We also found that not all the targeted states were the same in terms of survival. Louisiana had the lowest percentage surviving 5 years, followed by Mississippi and South Carolina. Next slide, please. So then we also looked at survival after AIDS diagnosis, so somebody who has progressed to meeting an AIDS definition. And what we saw was fairly simple. The targeted states, again, had the lowest survival percentages of any of the regions. The U.S. at 73%, the U.S. was 77%. So what that indicates is that over a quarter of people diagnosed with AIDS at 2003, 2004 had died within 5 years. So certainly not optimal where we want to be. And again, the targeted states had lower AIDS survival among women, Black or African Americans, and those living in rural areas. Next slide. And Louisiana, again, had the lowest AIDS survival rate, or survival proportion, excuse me, and Texas had the highest of the targeted states, but all 9 of the targeted states had lower survival proportions, AIDS survival proportions than the U.S. overall. Next slide. We are also interested in looking at deaths among people who are HIV positive in a slightly different way, and that was looking at the most recent available data at the time, which was from 2010, and we looked at the death rates among people living with HIV and found the death rate, not surprisingly, was higher in the targeted states than any of the other U.S. regions, and that living in a suburban or rural residence at diagnosis, older age, and Black African American race all were significant predictors of greater death rates among people living with HIV. So one of the things that we've heard hypothesized quite a bit about why there's higher death rates in people living with HIV in the targeted states region is that perhaps it's because there's a higher proportion of people who are living with HIV that are African American. And we know race has been a predictor of higher death rates. And the same could be said for rural living. So, you know, that there's more people living in rural areas, and that's also a predictor of higher death rates. So,
next slide, Matthew.
Yeah, next slide. Thank you. So we were able to do with the CDC collaboration, which was really something we were excited about being able to look at and to address that question, is we were able to adjust for those factors, for age, for gender, for whether you lived in a rural or urban area. And what we found actually was that the differences between the targeted state region and other regions in terms of death rates, they remained. So having a higher population of African Americans or people living in rural areas did not account for the differences in deaths. So how do we interpret that? Well, we know that there's probably other factors that influence those higher death rates in the targeted states. And I'm sure most people listening probably can speculate on what those factors may be, potentially things like HIV-related stigma, poverty, less access to quality HIV care. One important thing to note about looking at these death rates is that we don't know for sure what the cause of death was and whether it was HIV-related. So it's also possible these are including deaths from other comorbidities. So differences in death may also reflect differences in overall care availability between the targeted states and other parts of the country. Okay, next slide. I just want to talk a little bit about some analyses that we did looking at HIV and AIDS diagnosis over time. I think it's important to look at time trends just to show that these differences between the targeted states and other regions is not something that's sort of a one-year trend. It's something we've seen over time. And you can see that on this graph that the targeted states regions had a higher HIV diagnosis rate from 2008 all the way through the last year that we've analyzed, 2012. The target shown in red on this graph, and then followed by the rest of the southern states in green, and then the Northeast is in blue. So next slide, please. And this next slide just shows that the targeted states region also has a higher number of people who were diagnosed with HIV in all of the years between 2008 through 2012. The targeted states is again in red. In each of these graphs, the targeted states is noted in red, depicted in red. So the same thing we find for AIDS diagnosis rates. The targeted states have had higher AIDS diagnosis rates from that period, 2008 through 2012, and a higher number of people diagnosed with AIDS during that period. And next slide should be the one showing the percentage of HIV diagnoses that are Black MSM.
No, that's one more. Let's do the next one, and then we'll be there.
There you go. Thanks.
Yeah, we got it.
Okay. So one thing that we looked at also was wanted to look at whether there was changes in the percentage of HIV diagnoses that were among Black men who have sex with men, or MSM. And you can see that there has been a trend for an increasing proportion of new diagnoses to be among this population in almost all the regions. And you can see that actually the rest of the South has the highest proportion of, they're noted in green, they have the highest proportion of HIV diagnosis among Black MSM. So next slide. The CDC also looks at HIV and AIDS diagnosis rates in metropolitan areas of population of 500,000 or more. And what you see in 2012 is that all 10 of the metropolitan areas with the highest HIV diagnosis rates were in the South, and 8 of them were in targeted southern states. A similar trend for AIDS diagnosis rates. All 10 were in the South and 9 were in targeted states. So next slide, please. This slide just shows that of where all those 10 cities or metropolitan areas are that have the highest AIDS diagnosis rates in 2012. I think what sometimes people find surprising is who's not on this map. You don't see New York, you don't see San Francisco or LA. Really what you see now is these more mid-sized southern cities like Jackson, Mississippi, or Baton Rouge, and then Augusta, Georgia just joined this dubious honor of being in the top 10 in 2012. So next slide. I'm just going to change gears a little bit and talk about the HIV Infrastructure Study. This study was an effort to look at the HIV care and prevention infrastructures in 4 metropolitan areas in the targeted states that are, have been particularly hard hit and disproportionately affected by HIV. In these metropolitan areas, we were able to look at existing data on community health, but we also conducted interviews with people working in HIV care and prevention and advocacy, and focus groups with people living with HIV, just to try to get a better understanding of the structures for care in those communities, some of the gaps and barriers they experience, as well as wanted to document some of their strengths and look at some of the innovative programs that these communities are doing that they could share with each other. So next slide. The metropolitan areas we studied, you can see on this slide, were Baton Rouge, Columbia, Jackson, Mississippi, and Jacksonville, Florida. We also went to 2 communities that we refer to as the control communities because they have similarities in demographics to the other metropolitan areas, but they had lower HIV disease rates, and that is Birmingham, which of course is in the targeted states, and Cincinnati, Ohio. In each of the communities, we are generating a report that includes summarizing all the findings from that community, and then we will be synthesizing all of it into one larger report, and all of that will be available on the SASE website. Now I think Baton Rouge, Columbia, and Birmingham reports are on the website. Next slide. I'm just going to be talking about some of the findings from a few of the communities that we studied. The first one is Baton Rouge, and as I mentioned earlier, Baton Rouge has had some of the highest HIV and AIDS diagnosis rates. In fact, they had the highest AIDS diagnosis rate of any metropolitan area in 2011. They have particularly low AIDS survival, 3-year AIDS survival for those diagnosed in 2002 through 2006. 30%, almost a third, had died within 3 years. Women have been particularly affected by HIV in Baton Rouge. Over a third of diagnoses in 2010 were among women, compared to only 21% among women nationally. And of course, Baton Rouge has particularly high poverty rates, entrenched poverty, and poverty can certainly impact access to care and health outcomes. So some of the, next slide, please. So some of the barriers and kind of gaps in care that
Matthew, next slide. Matthew. There we go. Okay.
So some of the barriers and gaps that we have identified in the Baton Rouge area included HIV-related stigma. The stigma that we heard about in Baton Rouge was exceedingly high. Stigma was a common theme throughout all the interviews and focus groups we did in every community, even the control communities. But stigma was just exceedingly high and reported to be exceedingly high in Baton Rouge. We also identified some lack of adequate levels of services, some of these critical services in keeping people in care, influencing health outcomes, including behavioral health services, or lack of enough transportation, HIV case management. I'm sure no one will find it surprising that there is a lack of comprehensive sex education available in the Baton Rouge area, and there's inadequate levels of prevention funding, particularly from the state. On the strength side, there is reported to be generally available HIV medical care for individuals able to get to care and who can overcome some of the stigma-related issues. The care is there. There's certainly committed and passionate HIV service providers, advocates, and some innovative programs going on in that area. So now I'm going to talk just about Jackson, Mississippi. Jackson, like
next slide.
Next slide. Thank you.
Thanks.
Jackson has some of the HIV and AIDS diagnosis rate, a little bit different in terms of demographics. In Baton Rouge, nearly half of new HIV diagnoses in 2010 were among African American MSM. That's the highest proportion of any metropolitan area. Also, in 2011, they had the highest HIV diagnosis rates among men 13 to 24 years old, and again, high poverty rates in Jackson. Some similar barriers and gaps identified in Jackson as we found in Baton Rouge.
Next slide.
High levels of stigma, and then lack of some of the important services, or enough of the services needed in terms of transportation, behavioral health services. On the prevention side, certainly a lack of comprehensive sex education, lack of enough prevention funding and comprehensive prevention campaigns. And then we also heard a lot about a lack of political support for addressing HIV. On the strength side, they also have reportedly have enough access to HIV medical care, although it's more difficult for people living outside of the Jackson area that are in the MSA, but in the surrounding counties, because they have to, many of them have to drive or find transportation to care. They've had a recent increase in their supply of care, including an LGBT-specific clinic, the only one available in Mississippi. They also have a number of really innovative programs, including legal advocacy and a faith education project. So I just a little bit more about the stigma, and then this next slide, we can advance the next slide. I think what we heard in all of the communities, because we visited all 6 of them now, that the stigma is, HIV-related stigma, both experienced and perceived, is pervasive, it's damaging, it has negative influence on people's willingness to participate in HIV testing, in HIV care, in medication adherence, and HIV advocacy efforts. It's often exacerbated by a lack of education and trust. And although we heard reports certainly that it's more concentrated in minority communities, it really seems to be found in all communities, including sometimes in the healthcare. So just here at the end, you can see a few focus group quotes, and these are people living with HIV. One of my favorites is HIV doesn't kill, stigma does. I think that seems to be very appropriate for what we heard in these communities. And we also heard about some differences in stigma. We heard quite a bit about differences in stigma by age. So next slide, please. And I think this quote from a focus group participant really sums this up nicely.
Next slide. Next slide. Yep.
The focus group participant said, I was at a party and these teens were sitting off to the side of the porch and were talking about HIV as if it were a common cold. Literally. They were talking about it as if it were a common cold, but when you talk to somebody who is up in age, in their 40s or 50s on up, they look at it as a death sentence, no matter what you do, because they are associating with what they experienced in the past. And until things, it's just going to be time. That's the way I look at it. So generally, the theme that we heard was that, you know, some of the younger individuals sort of viewed HIV as something you could just take a pill to address. Although some of the folks we interviewed talked about how even when these younger individuals, once they actually were infected with HIV, they experienced a great deal of fear and stigma concerns. And there was one thing that we heard in Jackson, Mississippi in particular, and that was that some of the younger minority MSM would say things like, doesn't matter if I get HIV because I'm going to hell anyway. So just things that need to be taken in consideration when creating, and designing, and implementing prevention in the targeted states and probably other places as well. So just lastly, in terms of our upcoming research agenda, we're going to be updating our initial SASE comprehensive report on HIV in the South that was released in 2011. That needs an update. We're going to be completing our HIV Infrastructure Study. We're going to be conducting an HIV stigma study. Okay, next slide for this. And the
Next
purpose
slide,
of the
Matthew.
HIV,
Yep. Okay.
of the HIV stigma study is to really look more closely at people in the targeted states regions' experience with HIV-related stigma and the perceptions of stigma and how the stigma has influenced decision-making in terms of participation in testing and in care. So to do that, we'll be going back to some of the communities in the targeted states and interviews, in-depth interviews with people with HIV as well as surveying. So hopefully we'll be done with that in the next year to 18 months. So that's all I have. Pass it back to you, Carolyn.
Okay, so you can skip go 2 slides forward. Yep. So I'm going to talk a little bit about our advocacy agenda, and I'm going to focus primarily on this first topic on the slide, the CDC's high-impact HIV prevention funding policy and its impact on the South, because given the numbers you just heard from Susan, we really feel like we need to look very closely at how we can advocate for targeted prevention funding in these states that can be effective. So I'll talk about that in a minute. We are also engaged in advocating for the continuation of the Ryan White CARE Act. We think it's particularly crucial for our states because none of our 9 targeted states have expanded Medicaid. So the Ryan White CARE Act is really a crucial safety net program for people to get access to care and HIV medications. We're working in coalition with national groups to try and reach some consensus about what reauthorization should look like, but most advocates at the moment feel like the political climate is really a difficult climate to try and get a full reauthorization now through Congress. So we're also working hard supporting continued funding for Ryan White in its current form because we really don't want it to go away. We're working on the HOPWA formula modernization. So HOPWA is the Housing Opportunities for People Living with HIV/AIDS. It's funding for that population. And currently the funding formula is based on cumulative AIDS cases, which includes 53% of deceased people. So we're advocating for a more equitable formula that counts living HIV/AIDS and takes into account fair market rents and area poverty indexes. So we're working with the National HIV/AIDS Housing Coalition on that issue. And then finally, on the Affordable Care Act, we continue to support advocacy for Medicaid expansion in every state in our region, and also for Affordable Care Act insurance plans that don't discriminate against people with chronic conditions like HIV. For example, that they don't require high copays for specialty drugs like HIV, which we're seeing in many of the plans right now. So next slide. So I want to focus for a minute on this, on prevention funding. So in the past 5 years, the Centers for Disease Control and Prevention has implemented what they call the High Impact HIV Prevention Funding Policy. And there are many positive aspects of that policy, including the fact that funding is now based on the number of people living with HIV rather than on cumulative AIDS cases, which, as I said when we talked about HOPWA, included a huge percentage of deceased people. So that's great. The CDC also directly funds the 10 cities that account for approximately 37% of people living with HIV in the United States. And they also directly fund 36 jurisdictions with at least 3,000 African American and Hispanic residents living with HIV to support HIV testing for populations disproportionately affected by HIV. All those are very, very positive efforts by the CDC. Next slide, please. But when we looked a little closer at the CDC, how the CDC's policy applies to direct funding for community-based organizations, we see a problem. So the CDC, in their latest funding announcement, which was PS 15-1502, this was a funding announcement for direct HIV prevention funding to community-based organizations. And the PS 15-1502 specifically restricts eligibility for direct funding to CBOs to those located in designated metropolitan statistical areas, or MSAs. So a CBO that is located outside of one of these large urban areas that are listed in the funding announcement are not eligible to apply for funding. Next slide. So we took a look at our 9 states and did an analysis looking at the percentage of people living with HIV and AIDS who live outside a large urban area, or MSA, that would be eligible for funding from the CDC under this funding announcement. And as you can see here, in 4 of our states, more than 50% of people living with HIV live outside of a large urban area eligible for funding. So North Carolina, it's almost 63%. South Carolina, it's almost 70%. Alabama and Mississippi are also both above the 50% mark. Next slide. So I just want to take North Carolina as an example of the impact of this funding announcement. So North Carolina is number 10 in U.S. population. It's number 10 in the country in people living with HIV/AIDS, and it's according to very recent CDC data, it's number 11 in the country in the number of people living with undiagnosed HIV infection. And 63% of people living with HIV in North Carolina live outside an MSA eligible to apply for funding under this latest CDC announcement. So if you look at this map, you can see that North Carolina has a more dispersed epidemic. It's not as concentrated in the large urban areas as in some states, but it's rather more in the mid-sized cities. You can see along I-95 there, all those black splotches are smaller cities like Durham, Greensboro, Winston-Salem, and in the more rural areas. And this pattern is also true of Alabama, Mississippi, and South Carolina. And those areas are left out of funding for their community-based organizations from the CDC. Next slide, please. So we also took a look at the 12 CBOs in the Deep South who received funding from the CDC in 2004, and those 12 CBOs would have been ineligible to even apply under the 2015 standards, and would have lost almost $4 million in funding. And then in the 2010 CBO application, the loss would have been about $2.5 million. And this loss in direct CBO prevention funding is not made up by the state health department's CDC grant. So states also receive, the state health departments also receive CDC prevention funding, but they don't receive an additional amount to make up for what's lost under this latest funding stream from the CDC. Next slide, please. So we're thinking through right now what to advocate for with the CDC. We have been advocating for specific goals in the revised strategy, which is going to be released this month, so the revised National HIV/AIDS strategy, to target some resources to areas outside these large cities with the high diagnosis rates and the high mortality rates. But we're also supporting we continue to support the bulk of the funding going to these large cities most heavily impacted by HIV. That obviously has to continue, but we're asking the CDC to create an additional funding mechanism to directly fund CBOs outside of the large urban areas with high diagnosis rates and numbers and high death rates. According to very recent data released by the CDC, all 9 Deep South states are in the top 25 jurisdictions with the highest numbers of men who have sex with men with undiagnosed HIV. And our position is that we just can't end AIDS in this country if we don't address the epidemic in the mid-sized cities and the rural areas of the South and elsewhere in the country. Next slide, please. So I talked a little bit about I'm switching gears, I talked a little bit about our Ryan White advocacy. On this slide, I just want to point out that another thing that we're doing and that we've been running in the last year is a Ryan White Stories project. We're letting folks who live primarily in states that have not expanded Medicaid tell stories about why Ryan White is critical to their care and treatment, and why Medicaid expansion would be helpful. And we are continuing the Stories Project. We will be continuing that in the fall. So our email is up there on this slide. If you would like to tell your story, just send us an email and we'll have someone call you and interview you and get all your permissions and put your story up in our Stories Project. And we can even have you be anonymous if you want to be. And then last slide. So this is just our contact information. The website is up there and has all of the research reports, the infrastructure reports, the Ryan White stories that we've done. Many of them are up there. My contact information and Susan's contact information are both there. And it looks like we have even managed to get through this to leave just a few minutes for questions if anybody has any. Thank you all so much.
Thank you, Carolyn and Susan. If you have any questions, please hit the raise your hand button, and I will unmute you to ask your question. You can also ask your question in the chat feature. Anybody? Well, I'll ask the first one. You know, as I looked at your data, I started wondering, what can we do in terms of folks who don't live in these southern areas to support work that's happening in the South, and thinking about some of our own states that might have unthought about or unrecognized epidemics that are outside of MSA areas?
Well, I would say one thing I would say is that we do have a listserv in which we distribute our research reports and anything else that we think might be of interest to folks who are advocates in the South. And the email at the top of this slide, you could just email us and say you'd like to be on the listserv. So if you want to kind of keep up with what we're doing, that's another way to do that without even having to go to the website. You know, the analysis we did of our states in terms of the percentage of people living with HIV who live outside the large urban areas could be done easily in any state, and we would really like to see that done because nationwide, because I know that there are other pockets around the country that fall into the same, you know, that are similar to ours, and we'd be happy to share kind of where we went and got the data and how we did that with anyone who wanted to do that in their own state.
Gotcha. Renata, you have a question? Your line's unmuted.
I can't hear anything.
Renata from Emory? No? Okay. Let me check. Darrell, you have a question?
Hey, how are you doing? I'm Jarrell with the Arkansas AIDS Foundation here in Little Rock, Arkansas. And the question I have is, I'm trying to understand or try to see how do we get, I guess, PrEP and PEP more offered here in the state of Arkansas, because that's not a need for most physicians or doctors here in the state, or they don't see that as a high casualty at this current time. And I do consider us be a part of the South or part of the Deep South as well, because I have a high number of MSMs, Black MSMs out there who are infected with HIV.
Right, and we Arkansas is right on the edge of our 9 targeted states, and we actually do work a fair amount with advocates in Arkansas and try to include Arkansas in some of the work that we do. They don't have quite the heavy numbers that some of our states that we're more focused on do. So I just want to say that we love Arkansas, and we try to include them when we can. You know, I think the whole issue of PrEP and PEP in our states is tricky, and we're starting to look at how to advocate more vigorously around that issue, because we've got both the issue, not in Arkansas, but in the other 9 states of no Medicaid expansion, so we have difficulty with getting PrEP paid for, but also just getting the providers on board, I think is maybe almost a bigger issue. So you know, I don't have the answer to that, and I'm not. We're not in the middle of the PrEP advocacy, but we hope to be, because I think it's a real issue in the South.
No, thank you so very much.
Thank you.
And I was just going to add that there are some folks at the LGBT clinic in Jackson that might be particularly helpful to talk to, because that's something they've been pretty heavily involved in.
That's a good idea.
That's an open arms clinic. They might have some ideas, but that's certainly an issue in many of the places that we went to. Is a need for more PrEP and PEP availability.
Correct.
I have Glenda.
Hi, I actually, I guess you kind of sort of answered one of my questions, because from the beginning I was asking what was happening in terms of Arkansas, so that was just answered. But my other question deals with the listserv that you mentioned. So how does one become a part of that listserv?
Just send an email to the SASE email that's right on your screen right now, sase@law.duke.edu. Just send me an email with your email address and you're on the listserv.
Okay, and the last comment that I have to make is related to what you were talking about in terms of the prevention fund. So I'm part of an interstate kind of collaborative group that's looking for different things to do. Most of my career has been spent with AIDS prevention, and I had paid a lot of attention in past research work that I had done in looking at the Deep South. So how and when will we find out what you've been able to find out in terms of the CDC maybe opening up that money to look at those smaller cities?
The listserv is probably the place that we would send out any information that we get. Right now we're still in the kind of advocacy phase with the CDC, trying to get as many groups as we can to we've started kind of with the national groups. AIDS United has just agreed to send a letter to the CDC on this issue, and we've had one meeting with the CDC and with some heads of small CBOs in the South to talk about the problem. Why don't you email me? My email address is right up there too, and I'd love to get you involved in this, because Arkansas, it's something like 90-something% of your people living with HIV are outside an MSA.
Well, and I'll be honest, I'm actually here in Durham, which is right down the street from you and Duke.
Oh, okay. Well, then we should definitely talk.
Yeah, so because you're Carolyn, right?
Yes, yes.
Okay, I will follow up.
Okay, that would be great.
Thank you.
Any more questions, comments, concerns? Hopefully not a lot of concerns. Obviously,
lots of concerns.
Well, yeah, I think the data outlines some pretty evident concerns, but I think there's a lot of opportunity, and I think it's some great research and great information for folks really thinking about how do you take this back home and utilize this information to enhance your own efforts, and obviously a great new resource for folks. So if there are no more questions, I'd like to thank our presenters for a fabulous presentation. I'd like to thank all the attendees on being on our Brown Bag Lunch series. Let us know if you are when you're hosting yours in your town, and if you need some assistance. We have a little bit of money for food for folks, so do email me at matthewr@blackaids.org, and I hope everyone has a wonderful rest of their day. Thanks for joining us.
Great.
Thank you.
Bye.
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 I saw you on the webinar.